to join as we go through. There won't be barking. We have no rules in our house. I cannot control the dogs in our house. So that's unfortunately how it goes sometimes. But welcome to the April JVS Journal Club. We are thrilled to have everyone here. Today we have two exceptional papers from the April JVS. The first is Outcomes of Carotid Artery Stenting in Patients with Radiation Arteritis compared with those with atherosclerotic disease. We're lucky to have Samantha Mintz and also Dr. Luke Marone and their statistician Dylan Thibault, who's also here. And then we also have the second paper, which is Predictors of Mortality in Nonagenarians Undergoing Abdominal Aortic Aneurysm Repair, which is an analysis of the NSQIP improvement data set. And Dr. Graham Long is here to discuss that paper. Our hosts are from the University of Iowa and the University of Buffalo. One of the things we want to mention is about a special VAM session that will be going on Thursday, June 16th at 1:30. Gail Tang is the person who is helping us to promote this, and she will come on and actually talk about it at the end of the day. I'm going to put in a link as well, which has this QR code also attached to it. If you go to where the QR code is, you can submit suggestions, comments about what you would like to see from the JVS, and you can also participate in this session at the VAM as well. Very exciting for this session in Boston. Again, from the University of Iowa, we're thrilled that Dr. Rachel Nicholson volunteered to participate. She is a clinical associate professor of surgery, and she's the program director for vascular surgery there. She's joined by one of her residents, Dr. Nicole Ganinsky, who is a third-year integrated resident. From the University of Buffalo, Dr. Greg Clabo is with us. He's a clinical assistant professor of surgery, and their first-year fellow is also joining him. The authors, as I mentioned, that are joining us from West Virginia University, we are thrilled that Dr. Samantha Mintz can be here to discuss her paper, as well as her senior author, Dr. Marone, and their statistician, which I think will help us. And again, from the second paper, Dr. Graham Long, professor of surgery at William Beaumont School of Medicine. This month, we have two guest moderators. Dr. J.R. Chung, Associate Professor of Surgery at the Michael E. DeBakey Department of Surgery at Baylor College of Medicine, and Dr. Meryl Simon Logan, who's also in Texas. She's an adjunct professor or assistant professor of surgery at Texas A&M University, and she's also at the Central Texas VA. Just a couple of things for housekeeping. We'd ask that you please stay muted today. Put your questions and comments in the chat, and the moderators will help the authors address those, or our presenters discuss those. We are recording this for on-demand access. And then in May, our online journal club will be May 17th, which will be at 7 p.m. Central Time. This is posted in the SVS Connect. We also have it on the JVS website and the SVS website, and then we'll be posting it in the APDVS section for the SVS Connect as well. We've finalized the dates from May through August now and be posting them on the website. And finally, we've started working on September through December dates, as well as moderators, so we will be reaching out. I want to thank everybody for being here. And with that, I will turn it over to our first faculty introducer, and we'll get this party started.
Okay, are we sharing? We good?
Yeah, that looks great.
All right. All right, good evening, everyone. Thanks for having us, Dr. DiMuzio, Dr. Humphreys. So we get Dr. Polovich, our first-year fellow, like Dr. Humphreys said, and I are talking about the first paper, Outcomes of Carotid Artery Stenting in Patients with Radiation Arteritis compared with those with atherosclerotic disease. Just a little bit of history and thoughts that I had in reading and before, during, and after this paper. Radiation arteritis affects all 3 layers of the vessel, as opposed to just, medial disease or intimal disease, which atherosclerosis affects. But we've got long-term microvascular damage to the adventitia in the media, which, affects us in not just at the time of the disease process inception, but any subsequent attempts at repair are affected by that as well. Radiation arteritis and subsequent stenosis of more than 50% is present in as many as 29% of patients who get radiation to their neck, as opposed to 3 to 6% in the general population. Restenosis rates in carotid artery stenting are between 5 and 14% without radiation. One of the great points about this paper is it's just not very well studied in patients who have been radiated. There is suggestions of increased restenosis in radiated necks in small studies in the past. Rather for dating myself, my most up-to-date edition on my bookshelf is the 7th edition. But the 7th edition is coming out soon, so I'll be upgrading. But there have been some small studies. The institution had impressive, well, it's the VQI. We had impressively low restenosis rates in the prior radiated therapy arm, as well as low average in the non-radiated arm. So those were good to see. So what was one of the biggest take-home points from the study was when we looked at the mortality rate, the mortality rate across the board in patients who underwent stenting. The radiation arteritis patients had a 9.4% 3-year mortality rate. The atherosclerotics with unradiated necks were 7.5%. And that, after statistical evaluation, that comes out to a 58% increase in risk of mortality, which is substantial. So Dr. Polovich is going to get into the nitty gritty on that. But just, from our institution, a quick thought, that I wanted to add in on the radiated neck is, myself and my partners will take every case on an individual basis. Always an increased level of concern with that history of radiation, obviously. But we have found that, on physical exam of the anterior cervical triangle, if you don't have a lot of, woody fibrosis that's affected the skin, or, you can sometimes just palpate the sternocleidomastoid, in the absence of real dense fibrosis, we have found that, surgical exposure is not overly treacherous. We have taken a look at just an internal evaluation. We haven't had any increase neurologic events or otherwise, or even cranial nerve deficits. So that's just our evaluation. Long-term survival, we have not assessed critically. So what's causing the increased mortality? We have got a lot of sharp minds that can lend into this. Unfortunately, in this paper, the cause of death wasn't readily available for everyone, or many of the study participants. So it kind of begs that question. Another question that came up was how many of the radiated patients underwent chemotherapy? A history of head and neck cancer, history of chemotherapy. Has it affected our long-term tissue viability across the board? And is that lending to overall increase in mortality? The other one that came across in discussion was, did this include TCAR as well as transfemoral stenting? And it sounds like the answer to that is yes, because this is a VQI registry. So with those things being said, I'm going to turn it over to Dr. Polovich and stop sharing.
Thank you, Dr. Globo. Thank you, Dr. Humphreys and Dr. DeMuzio for this opportunity. So I'm going to go ahead and dive right into the paper. Current prospective and retrospective studies of patients who had received head and neck radiation and had undergone duplex ultrasound revealed greater than 50% carotid stenosis had occurred in up to 1/2 of the radiation therapy patients compared with those who did not. Conventional carotid endarterectomy in patients who received radiation is associated with increased incidence of permanent cranial nerve palsy, as well as wound healing complications. These significant complications have resulted in stenting being the procedure of choice in irradiated fields. The purpose of the study was to evaluate the difference in outcomes between patients who had undergone carotid artery stenting for atherosclerotic indications versus those for radiation arteritis. Specifically looking for differences in the incidence of restenosis, reintervention, and freedom from mortality between the two groups. National VQI database of prospectively maintained carotid artery stenting dataset was surveyed. Cases between 2016 and 2019 were queried. Complete case analysis of the key variables was performed, and those included age, sex, multiple comorbid conditions, urgency, symptomatic status, prior intervention, some demographic information, primary insurance, preoperative dialysis status, and smoking status. Patients with significant missing data were excluded from the study, and primary endpoint was the interval to mortality. Secondary endpoints were perioperative complications and the cumulative incidence of restenosis and reintervention. Perioperative complications included myocardial infarction, in-hospital mortality, neurological events, ipsilateral stroke, and contralateral stroke. Restenosis was defined as either greater than 50 or greater than 70% as reported on duplex ultrasound, and reintervention was defined as any intervention, surgical or catheter-based, within the 90 days of the treatment. Moving on to the results, of 7,343 patients, 7,218 patients met criteria for analysis. 6,019 patients had stenting done for atherosclerotic disease, and 1,199 patients had stenting for radiation-related stenosis. Statistically significant findings included younger age, lower BMI, and a greater number of male and white patients for prior radiation group. The radiation patients were also more likely to have not undergone a prior intervention, or if they did have a prior intervention, they most likely had stenting. Radiation patients were also more likely to have undergone an elective procedure, as well as to have commercial insurance. Patients without prior radiation has had high rates of comorbid disease. There was no statistically significant difference found regarding symptomatic status between the two groups. On Kaplan-Meier analysis of all-cause mortality, the authors found a statistically significant difference in the mortality rates between the two groups, with radiation patients having a greater risk of all-cause mortality. In this figure 2, graph A, the Kaplan-Meier estimates of all-cause mortality, and the graph B represents Cox proportional hazard estimates of risk-adjusted mortality, both over the 3-year period for between the two groups, and both are statistically significant in this case. There was no difference found in restenosis and reintervention rates between those with and without radiation in cumulative incidence function estimates or grade test results. Reintervention was required most often within the first 90 days after the initial surgery, and the data in the 90-day period was not analyzed due to low numbers. After adjusting for the patient case mix, patients with prior radiation had 58% greater risk of mortality at any time point compared with those without radiation. No difference was found in the rates of reintervention or restenosis when accounting for the competing risk of death between the two groups, and no statistically significant differences were observed in perioperative outcomes between those with and without radiation. So this table 2 shows differences in mortality, restenosis, and reintervention rates over the time stratified by radiation. On log-rank testing, the difference in mortality was noted as early as 30 days postoperatively and increased throughout the study period, with 3-year mortality rates for radiation and atherosclerosis patients being 9.4% and 7.5% respectively. The grade test was used to evaluate the 3-year incidence rates of restenosis of greater than 50 and 70%, as well as reintervention, and those were found to be not statistically significant in this case. Figure 2, graph A, represents cumulative incidence function estimates of restenosis greater than 70% over the 3-year period between the two groups, and graph B shows cumulative incidence estimates of reintervention over the 90-day period between the two groups, and both of those are not statistically significant. Adjusted hazard ratios on table 3 was used for risk of mortality, risk stenosis, and reintervention. And the authors found that patients with prior radiation had 58 greater risk of mortality compared to those without, and that's after adjusting for the patient case mix. Table 5 represents the differences in perioperative outcomes after stenting between the two groups, and none of the outcomes were statistically significant. I'm going to move on to the discussion portion. Present study represents the largest analysis of carotid artery stenting outcomes for patients with history of head and neck radiation, adding more insight into both perioperative and midterm outcomes. The analysis revealed that no significant differences were found in perioperative outcomes between the two groups, nor was the risk of restenosis or the need for reintervention during the follow-up increased significantly. Significant midterm mortality difference was identified in the 3-year estimates between the two groups, with mortality of 9.5 versus 7.5% for those with history of radiation versus those without. This difference increased after adjusting for the patient case mix, with radiation patients having 58% greater risk of mortality compared to those without. And these findings could help shape the discussion in the consent process of stenting and the decision to intervene, especially for an asymptomatic patients with history of radiation. Notable finding in the study was no difference were present in the risk stenosis and the reintervention rates between the radiation patients and atherosclerosis patients. The issue of risk stenosis after carotid artery stenting patients who had previously undergone radiation had been evaluated in several studies, but with conflicting findings. So this study had significantly larger patient population compared to those other studies than it included, and which might have contributed to the differences in the findings that we see here. Another important finding from the present study was a significant increase in mortality for the carotid artery stenting in radiation cohort compared to those without. And one might assume that the patients with a history of cancer might have a greater risk of mortality than those without. However, the non-radiation group represented patients with advanced atherosclerotic disease who had been deemed too high risk for carotid endarterectomy. The finding of mortality difference is consistent with that from other studies. Favre and colleagues evaluated 149 carotid artery stenting patients with prior radiation with a mean follow-up of 30 months and had identified 6% mortality at 1 year and 22% mortality at 3 years. These results had insight into the cause of the increased mortality in the radiation cohort because they reported that the most frequent cause of death in the radiation population was progression of disease, which is cancer, and not the cardiovascular events as one would expect in the atherosclerotic group. Some of the limitations. So the authors were limited by the available data for variables in a data set, and more specifically, the cause of mortality. This variable was not complete in 81.4% of patients with no mortality. Also, there was no method to determine how much time had elapsed between the patient's exposure to radiation and them undergoing stenting. Restenosis was another variable that was also limiting in the study, and the number of patients available for long-term analysis. So the number of radiation patients available for analysis at 3 years of follow-up decreased from 1,199 to 192 in mortality analysis and from 281 to 66 in restenosis analysis, which decreased the statistical power of this study. So in conclusion, carotid artery stenting patients with radiation had significantly higher mortality at all time points than those without radiation, even after adjusting for other covariates. No significant difference was found in the incidence of reintervention, restenosis, and perioperative complications between the two groups. The present study was unique owing to the large sample size and length of follow-up. Findings suggest that carotid artery stenting in this high-risk group provides the same patency as it does for patients with atherosclerotic disease, while avoiding potentially morbid nerve injury and wound healing complications. Thank you.
Okay, so thank you. And thank you, Dr. Mink. That paper was really fabulous to read. So I had a question myself, and then I'll take some questions from the chat. It looks like we have one question so far, and it kind of goes along with my question. So how do you see this data being used moving forward? How do you think it should change our practice and who we decide to intervene on? And Dr. Humphreys, also, in addition to that, were there any specific factors that might help you decide who should be intervened on?
So thank you for that question, and thank you everyone for reading the article and for your interest. So I think this article brought up a lot of questions, and the more I tried to answer the questions with things that I thought made sense, the more confused I got. So when I look at, again, this carotid atherosclerotic disease group of these very sick patients that were too sick to have some kind of open surgery, I really would expect, based on what we know of our disease process of vascular patients, that they would not do as well as often these kind of younger radiation patients. And kind of the nature of their disease and progression, I just thought would be different. And even if you look at other parameters, so things like socioeconomic status, it looks like the radiation patients actually were more likely to have commercial insurance, less likely to be on Medicaid. That would usually be a marker of someone that would be sicker or not have the same access to care and maybe have a lower life expectancy. And there was, some other factors that we thought would make sense. So the carotid stenting patients with atherosclerotic disease were more likely to require an emergent or an urgent case, while the radiation patients were more likely to be elective. They were equally likely to be symptomatic or not, but just that factor also is one of those where when patients are coming in with advanced urgent disease, we think they may be sicker, their health is poor at baseline, so they shouldn't do better. And yet, despite all that, we still found this mortality difference. So I did think that was pretty interesting. So how this can affect clinical care, and that was an important question that the reviewers did pose us when we were going through the submission process, and I did have to think about it. And I do think that this kind of how it informs your discussion with the patient that has that asymptomatic stenosis, whether or not you will offer them something, that's where I see it makes the most sense. And I would love to hear if anybody else thinks of any other aspect where it might be helpful, because otherwise this data is kind of saying, well, if the restenosis rates or the reintervention rates are the same, just go ahead. But what's stopping you, other than this mortality information? So there was so Dr. Humphreys asked a question about what other factor then. And as I was saying, I was kind of combing through the factors that we did look at, and there didn't look like there was anything that made sense there. But one thing I could think of is potentially, what about their nutrition status and frailty status? And maybe if they have a recurrent cancer and we pick up on their malnutrition, which can sometimes be like one of the first signs of unexplained weight loss, something like that, maybe that might have us go sending them to their oncologist rather than doing a carotid on them. Maybe that's an idea. I was just thinking, what other things in that particular patient population. I see there are other questions popping up, so I'm going to take a look. But
Yeah,
those are kind of my answers there.
Yeah. So
Sam,
oh,
I was just going to add to Sam's comment. I think one of the things we can do is, from a vascular perspective, we see patients that are sent to us with radiation arteritis and a stenosis, and they've had this history of head and neck cancer. But what we often forget, we see stenosis, want to treat it, we think we're doing good, but what we often forget is that a large percentage of these head and neck cancer patients have concomitant or down the line, they develop lung cancer lesions, because it's often tobacco-related head and neck cancer. And there's an exceedingly high rate of developing lung lesions later on. So I think giving these people better screening related to a chest x-ray, or maybe more than a chest x-ray or CT screening. Now we do CT chests for screening of for lung cancer, might be in order to detect an occult or small malignancy that may actually be causing their long-term mortality issues, meaning short and mid and long-term mortality issues. Just one of the thoughts I had, and that's what I'll do more aggressively in the future after looking at this paper and this data.
and I think that also partly answers Dr. Lawrence's question, which is what study in the future should be done to determine the cause of increased mortality. Another question from the chat is, what is the risk of TIA or stroke in the asymptomatic patients with radiation arteritis and greater than 70% stenosis?
I am not sure there is data on that. That would be another interesting area to look at. It looked like they were as symptomatic as the atherosclerotic patients, but that's, I think, a great question.
Yeah. Another question, radiation can result in lesions that are not typical in terms of location, sometimes in the common carotid or diffusely. I was surprised that the perioperative results were similar. more of a comment. How about, do you think there was a selection bias, as Dr. Clabeau mentioned, about the degree of fibrosis in the skin, and maybe not all radiation patients are the same?
So that's a good question. I guess I can only be anecdotal about it, but I do think, especially over the last decade, when the opportunity to put a stent in came up, I was pretty psyched to do it. So as soon as I saw radiation, I was like, all right, indication. And I would guess a lot of our colleagues may have been like that, but that is anecdotal. And I think you're right, though, that, yeah, maybe someone might be like, well, the skin looks good and maybe you should just go ahead and do it. And I also agree with Dr. Damasio, like it doesn't make sense to me that there's no difference. And I just think we need more people to study in the long run to really understand this.
Yeah. Another question that I had was, were you able to break out the symptomatic versus asymptomatic radiation patients and see if they had a mortality difference amongst themselves by any chance?
So that's a good question. So I just, we knew that the symptomatic versus asymptomatic were similar between the two groups. I think from a statistical standpoint, the number is going to be too low.
Too small.
Yeah.
It would just be interesting to know if those are the patients that are then sicker and had a higher mortality, but yeah.
Yeah, well, so looking at the info here, we have 574 patients that were symptomatic. So about half of them were, 50% about were symptomatic. So you'd have like 250 of each you could probably look at. It could be something that we could look at.
Another question from the chat: prior literature and anecdotal experience suggest different lesions characteristics after radiation. Was there differences noted here, or does selection bias wash out the differences?
I think just with the VQI data set, that is a limitation.
Yeah. Well, unless anyone else has any other questions, those are all the questions from the chat and from myself. Thank you.
Congratulations again on a great article. The last month we also did an article on radiation in carotid disease. And so I think there is a lot going on here that people are curious about. And just yesterday, my junior partner asked me about what to do for a patient with a radiation-induced lesion. So I still think there are questions that people have that when these come up. So we will now move into our next presentation. We are again excited to have Dr. Rachel Nicholson start us off from the University of Iowa, and she'll be introducing her topic in the paper.
All right. Good evening. We're really excited here at the University of Iowa to co-host tonight's journal club with the University of Buffalo. I'd like to thank Dr. Humphreys and Dr. Damasio for the work they've done to organize this online series, as well as the opportunity to present the work of Dr. Long and colleagues from Royal Oak, Michigan, entitled Predictors of Mortality in Non-Octogenarians Undergoing Abdominal Aortic Aneurysm Repair, Analysis of the National Surgical Quality Improvement Program Data Set. So we are not getting any younger. The US Census Bureau projects that in 2034, for the first time in US history, the population over age 65 will exceed those 18 and under, with a continued upward growth in the aging population through at least 2060. If the population follows these projections, the United States will look dramatically different over the course of a century, from a population that was pyramidal in shape with the largest number of people comprised of those 18 and under, to one that is more like a pillar, as seen here in this depiction on the right. When we specifically look at the projections for those over 90, there's a marked increase in the age group expected in years to come. In 2016, there were 2.5 million people in the US over age 90. And by 2050, this is expected to exceed 8.3 million. Therefore, many of us will face the clinical challenge of managing vascular disease in nonagenarians in our future practice. So the association between aging and vascular disease, and in particular abdominal aortic aneurysm, is well known. However, many prior studies have looked at the populations older than age 75 without specifically pulling out data on octogenarians and nonagenarians. In 2013, Savji and colleagues published one of the largest series looking at the results of over 3.6 million lifeline screenings, evaluating the association between advanced age and vascular disease. Their analysis was performed on information obtained from the Lifeline screening database and included patients with peripheral arterial disease, carotid occlusive disease, and abdominal aortic aneurysms. Their analysis was one of the largest to specifically tease out data on the octogenarian and the nonagenarian populations. And this included over 200,000 patients aged 81 to 90 and over 10,000 patients aged 91 to 100. Their study showed an increase in the prevalence of abdominal aortic aneurysm with each decade of life and was consistent in both men and women. So with the expected increase in this population, along with the increase in prevalence of aneurysm and disease with age, it could be anticipated that many of these in the future will be interested in aortic repair once their aneurysms reach a size at which guidelines recommend repair. So additionally, a number of them will present with a ruptured aneurysm. Therefore, studies specifically looking at outcomes with this population are important to guide management in the future. Currently, there is limited data published on the topic of aneurysm repair in this population. Many of these studies are small, single center experiences, as shown here, just to say, show a few. And then this can sometimes raise questions like the one asked by Sanasan et al., which was, is there an age limit for abdominal aortic aneurysm repair? In an effort to answer this question, their meta-analysis reviewed additional publications that included patients 80 and older who underwent repair. 11 studies met criteria and were included in their analysis, in which they found a high 30-day mortality with elective and emergent open repair, as well as emergent endovascular repair. So that brings us to the journal club article for tonight, entitled Predictors of Mortality in Nonagenarians Undergoing Abdominal Aortic Aneurysm Repair, which is now the largest series published on this topic. This will be presented by Dr. Nicole Jensick, who is a third-year vascular surgery resident here at the University of Iowa. So let me stop share.
Alrighty. So hello, my name is Dr. Nicole Jensick, and I'm a third-year integrated vascular surgery resident at the University of Iowa Hospitals and Clinics. I'll be discussing the article entitled Predictors of Mortality in Nonagenarians Undergoing Abdominal Aortic Aneurysm Repair, analysis of the National Surgical Quality Improvement Program dataset by Dr. Kumar and colleagues. The median age of abdominal aortic aneurysm repair is 73 in the United States, with a perioperative mortality rate of 0.84 to 5% for elective endovascular aortic repair, and 4 to 8.5% in elective open surgical repair. Multiple factors, as we will discuss in this paper, increase the risk of perioperative mortality, including emergent indications for operative repair and patient age. In 2016, JVS published an article by Dr. Hicks reporting the increased 30-day perioperative mortality rate in octogenarians after AAA repair of 0 to 21% in elective settings and 29 to 59% in emergent settings. As the global population ages, we are expected to see an increase in the US population to 8.3 million individuals over the age of 90 by 2050, emphasizing the need for an updated and comprehensive subgroup analysis of nonagenarians to drive evidence-based decision-making. The purpose of the article we are discussing today is to meet that need for data-driven evidence regarding the predictors of 30-day mortality and morbidity of nonagenarians undergoing endovascular aortic aneurysm repair compared to open surgical repair in both emergent and elective settings. This was achieved through a retrospective review of the NSQIP dataset from 2005 to 2017. 1,356 individuals were identified that met the criteria of age 90 to 99 years and at the time of their AAA repair. Of these individuals, 90.6% underwent EVAR and 9.4% went open surgical repair. Further breakdown shows that 82% of the EVAR cases were elective, whereas only 37% of open surgical repairs were elective. Multiple data points in the NSQIP dataset were examined, including the patient demographics listed here to include sex, smoking status, history of COPD, hypertension, congestive heart failure, diabetes, renal insufficiency, functional status, and ASA classification. Intraoperative and hospital events such as ventilator dependence, blood transfusion, anesthesia time, total operative time, and length of stay were also reviewed in order to further understand the predictors of our primary outcomes, including in-hospital mortality, 30-day mortality, and the secondary outcomes of postoperative complications and perioperative predictors of mortality. An overview of the 30-day mortality in all nonagenarians, regardless of circumstance, was 10.4%. Statistical significance was found in all comparison groups between open surgical repair and endovascular repair among this population, regardless of emergent or elective nature of repair. 30-day mortality rate for EVAR was 2.6% in elective cases and 28.6% in emergent cases. 30-day mortality rate for open surgical repair was 19.1% in elective cases and 53.7% in emergent cases. Additional subgroup analysis reviewed the postoperative complications. I've listed here the statistically significant differences between endovascular and open aortic repair in their defined categories of elective and emergent. Significance was found between elective endovascular and open repair in the following complications: wound disruption, cardiac arrest requiring CPR, ventilator support greater than 48 hours, bleeding or need for transfusion, sepsis, septic shock, and return to the operating room. In emergent procedures, statistical significance between endo and open was found only in the need for ongoing ventilator support beyond 48 hours. Predictors of 30-day postoperative mortality were reviewed between endo and open repair. Ventilator dependence, necessity of blood transfusion, and total operative time demonstrated significance in 30-day mortality for endovascular repair only. Length of stay, on the other hand, was found to be significant for open repair only. Now, 3 predictive factors transcended the methodology of repair to show significance for open and endo repair. These factors included functional status, ASA classification, and emergent indication. Based on these findings, a preoperative risk factor scoring system was created as a surrogate for a simplified and practical fitness test. Functional status, ASA classification of 4 or greater, emergent procedure, and open surgical repair were each assigned a single point. Of the 1,356 patients in the dataset, 1,338 included all 4 of these parameters, and that data was utilized to analyze the associated preoperative risk score. As you'll see, an individual with no risk factors was a preoperative or had a 30-day perioperative mortality rate of only 2.2%, whereas with all 4 risk factors, they had a quite alarmingly high 30-day mortality rate of 73.7%. The utility of this article comes to a head in how we use it to further discuss and inform decision-making with our patients regarding AAA repair. Age alone should not be used as a disqualifying factor. The life expectancy of a 90-year-old is 4.5 years, and that life expectancy only drops to 3.2 years at the age of 95. The life expectancy of a man does not drop below 2 years until the age of 102, and for women at the age of 104. Meanwhile, the 1-year risk of AAA rupture at the size of 5 to 5.9 centimeters is 3 to 15%. At 6 to 6.9 centimeters, that risk rises to 10 to 20%. And at greater than 7 centimeters, that risk is 20 to 40%. Utilizing the data in this article, we can state that the 30-day mortality risk of elective EVAR is 2.6% in a nonagenarian. By utilizing the preoperative risk factor scoring system, if our patient has an ASA classification less than 3 and has an independent functional status, by definition, their individualized risk score for elective EVAR is 2.2%. Based on this data, if the patient's AAA meets the requirement for repair, they should be classified as a good surgical candidate. That being said, when a patient presents in an emergent fashion requiring an open aortic repair, meeting all 4 risk factors, their 30-day mortality risk alone should not automatically disqualify them from repair. Emergent open aortic repair global mortality risk is 53.7% in this study, and that individual's risk score is 73.7%. Granted, no surgical repair would ultimately result in essentially 100% 30-day mortality risk. However, that being said, the difficult recovery and ultimate functional status after surgical intervention, even if the patient beats the odds, may not align with their wishes. The value in this article is giving the patient and their families the numbers to help them make that choice. This type of individualized approach should be utilized for all patients in discussing elective AAA repair in the office to emergent scenarios for ruptured AAA. In summary, nonagenarians have an acceptable 30-day risk of mortality with elective EVAR and are comparable to octogenarians for emergent EVAR. For ideal surgical candidates, proactive elective repair should be preferred to observation, especially with the risk of rupture, and if it can be endovascularly pursued. And finally, a simplified and practical preoperative risk factor scale can be utilized to inform the discussion for AAA repair and identify the appropriate surgical candidates. A limitation noted in this study is related to some data points that are not present in the NSQIP data set itself. Quality of life and level of independence after AAA repair is not examined. In addition, the limited number of patients in the open surgical repair arm of the study likely limits the ability to determine statistical significance in some predictors of 30-day mortality. For example, the need for transfusion and total operative time are likely factors that would prove to be significant with a larger population enrollment. Additional source of bias within the open surgical repair group is that the patients are unlikely to represent a typical nonagenarian. For example, none of these patients were on dialysis and most maintained a good functional status. Finally, due to the nature of the data set, it was not possible to characterize the type of abdominal aortic aneurysm if it was infrarenal or suprarenal. The complexity of the repair was not quantified, and adjacent techniques utilized in repair was not detailed. I want to thank the authors and JVS for allowing me to present this article, and I'll turn it over to our moderators.
Congratulations, Dr. Jensicki, on a great paper and a great presentation. So we'll start with some questions from the chat. So the chat, first one from Dr. Harris. Do you think that the emergent and elective patients are comparable groups, or that the emergent may have declined or not been offered elective repair?
So first, many thanks to Paul and Misty for the invitation to participate this evening and the consideration of the paper by the group. In terms of the comparison groups, we did divide them up into the four. We stated the overall results first, and then divided them up into the four groups to state their results. But no, they're not strictly comparable in terms of elective versus emergent patients.
Okay, next question is from Dr. Forbes, who says that, I guess 90 is today's 70. Do the authors think that AAAs of the same size have similar rupture risks in those that are in their 90s versus somebody who is, say, 75, all other factors being equal? He has no evidence to support this, but his theory is that the rupture risk in those over 90 would be lower in equal size aneurysms because by definition, they had a more indolent course.
Can you repeat the last part of that question?
The last part was just sort of an opinion. His theory is that those that are nonagenarians, compared to somebody who's age 75, let's say you both have 6 centimeter aneurysms, he thinks the 6 centimeter aneurysm in a nonagenarian has less of a rupture risk because it's had, by definition, a more indolent course. So he's kind of wondering what your thoughts were on that.
So there's not any evidence that we came across that would indicate that the advanced age is protective for any given size of aneurysm. And of course, different patients develop aortic aneurysms beginning at different ages. And so we can't assume that any given patient, any elderly patient has had an aneurysm longer than, say, a younger patient. So I don't think that I can give any, shed any light on that or support it from that standpoint.
Okay, next question is from our medical student, not quite Dr. Maxwell. By the way, it doesn't matter that you're a pre-med student, just FYI. I think all your questions are great. But in any event, is there any concern with selection bias comparing the statistics between the EVAR versus OSR groups, considering that the OSR data set contains much fewer patients?
So the way the NSQIP algorithm works is that patients are enrolled in a rolling fashion every 8th day, so that there's not any selection bias in terms of the same surgeon operating the same day of the week, so that if one day of the week was chosen for enrollment of patients at a given institution, then there would be a mechanism for bias. So that the rolling every 8-day enrollment addresses that. I don't think that there's any enrollment bias for patients just on that basis.
Okay. Next question is from Dr. Lawrence. Dr. Lawrence notes that the NSQIP is used primarily by hospitals that have lower volume and therefore less experience than in VQI hospitals, which use that database at many academic and high volume aortic centers. Do you think that the mortality would have been lower in the VQI hospitals?
So I'm not aware that the NSQIP hospitals have lower volumes than the VQI hospitals. So I don't have any evidence to support that theory. And I don't really know how to address it any further than that.
Fair answer. Last question from Joe Luis Pantoja at UCLA. He's a PGY5. He was wondering how functional status was assessed. And I guess by extension, we'll just ask you, do you think that has an impact on the outcomes?
So functional status in terms of dependence, functionally dependent or independent, is defined specifically by the NSQIP group, so that the folks abstracting that data from patient records are using the same definitions, and that's one of the strengths of the NSQIP system. The functional status was one of the factors that was one of the preoperative factors that we found was predictive of mortality, and that was the basis for its use in the subsequent scoring system.
And just by extension, so there have been prior papers that have utilized NSQIP to calculate frailty scores, and then by extension, then use that frailty to see how frailty impacts the outcomes. Did you guys take a look at that, just out of curiosity?
So frailty is not one of the variables recorded in NSQIP, so it was not able to be addressed in the analysis.
So the next question is from Dr. DiMuzio. He's just kind of curious, in the design of your study, what attracted you to the NSQIP dataset versus other databases?
Yeah, that's a great question. So ultimately, the NSQIP program is what our hospital enrolled in a number of years before the VQI, and so we had a fair number of patients enrolled ourselves, and so we decided to go with the NSQIP program instead of the VQI.
And just as a follow-up to that, do you think there are some inherent pros and cons to that decision versus NSQIP versus the VQI, for instance?
Well, I think that that the strength of the NSQIP infrastructure is that rolling enrollment. It helps address any bias. It's the definitions of the different variables are strictly defined and used by trained abstractors. So it's a very well honed system, and so I don't know that it's better or worse than the VQI system, but it certainly stood the test of time in terms of its the robustness of its data and the numbers of patients enrolled.
Fair. Seems I missed a question. Sorry, Dr. Main, but he asked a question. He was interested to know why the data was collected only until 2017. He was thinking you might be able to get more N and perhaps more modern data by going to 2021. Is that simply availability?
Exactly right. The files are brought out every 5 years, and 2017 was the latest available.
One final question from Dr. Marone. What about the Medicare data set? Wouldn't this provide more longitudinal follow-up? I expect it's very expensive and not everyone has access to that.
So I'm aware of that data set. I'm not aware of how to get hold of it and whether or not our hospital would be willing to pay any fees necessary to get hold of it.
It's expensive.
Got it. Thank you.
One final question from me, since I get the conch, so to speak. So I was wondering about your risk score. It was interesting. Most risk scores generally apply a larger risk or a larger number value in the risk score to those variables that are more impactful on the outcome. So for instance, the emergent status had an OR odds ratio of 15, which is compared to the ASA that had an odds ratio of, I think, 5, if I remember right. So how did you guys decide to ascribe only a single point score? And the reason why I asked is that perhaps you could get a risk score that better predicted, or who's going to die and who's not, if you had coefficients that better matched.
It's an excellent question, and we were somewhat skeptical of the validity of the score that we came up with, just assigning 1 point for each of those data points that are listed. We then went back and created a weighted score based on those odds ratios that you mentioned, and the outcome, the mortality rates were actually very similar to the one that we initially came up with. And in the interest of keeping it simple and hopefully increasing the likelihood of it being adopted in some fashion moving forward, we stayed with the simpler one.
Outstanding. Well, again, congratulations on a wonderful presentation. And again, thank you to Dr. DiMuzio and Dr. Humphreys for the privilege of discussing the paper.
Thank you all very
Dr.
much.
Chung as well. And thank you, Dr. Long, for answering all of those questions. I'm going to share my screen one more time. Gail Tang is here to again talk about the JVS session at VAM.
You should be seeing some Twitter polls so that people can vote for the topics of most interest. But for those who are not necessarily so Twitter savvy, we have this form link where you can enter topics and suggestions. So you just scan in the QR code and add additional topics so that we can better tailor the program to things that are topical and of interest to the audience. Thanks, Misty.
Of course, thank you for coming on, and we appreciate everybody being here. The dogs are very excited, thought there was a great discussion, and we look forward to seeing everybody in May. Jared just said the QR code did not work. A little bit higher up, I put the link to it, and I can add that link back in real quick for those of you who want to go and that want to go and check it out. So let me see if I can just
I
cut and
tried
paste.
focusing in on it. It actually eventually came on after about 10 seconds by taking it.
Okay. Okay. Well, then I will still add the link in there in case anybody wants to go, just click on the link. And then you can also look on Twitter for that information. And thank you everyone for being here, and we'll see you again in May.
Thank you, Misty, and God bless everyone. Happy Easter for those who celebrate.
Thank you, everybody.
Thanks, everybody.
Easter. Take care.
Mm.